What if I told you that a simple blood test for prostate cancer reduces the finding of locally advanced or metastatic disease at the time of diagnosis from nearly 60% down to about 25%? You'd say, wow, intuitively would make sense that finding the disease earlier in its course would be essential to improving survival. True for some, but do we really need to find all of these cancers? When the PSA blood test was FDA approved in 1986 for monitoring men with known prostate cancer, it also rapidly became adopted as a screening test for the early detection of the disease at the same time that I was in my residency in urology. So, although it turned out to be somewhat controversial, this was an important breakthrough that I got to witness from the very beginning of my career in urology all the way to the present time. I can remember more than 30 years ago the first patient that we diagnosed with prostate cancer on a PSA-triggered biopsy. Elevated PSA, but no nodule on digital rectal exam, which was previously the most common way of detecting cancer. So these patients received definitive treatment because we did not have a clear strategy at that time to recommend active surveillance. It was unknown whether a delay in treatment might be detrimental. Prostate cancer is the most common non-cutaneous malignancy among adult men in the U.S., surpassing the diagnosis of lung cancer in 1984. Over 200,000 men will be diagnosed with the disease this year, an estimated lifetime risk of 1 in 8. Screening for prostate cancer with PSA in the 1990s created this huge spike that you see in the graph. PSA tests generated a large group of men with low-grade, low-volume, clinically insignificant prostate cancer, and many of those men were overtreated. It has taken years to validate and implement the strategy of active surveillance, and it is no exaggeration to say that in the last decade, the most important advance in the treatment of prostate cancer is, ironically enough, the decision not to treat it. We should have known for a long time that not all prostate cancers need to be treated aggressively. A recent analysis of autopsy studies estimates that nearly 60% of men who die in their 80s of other causes have histologic evidence of prostate cancer. And it has a reputation of being very slow growing. We've all heard the expression that the majority of men die with their prostate cancer and not from the disease itself. Despite this, we as urologists embarked on a program of mass screening of asymptomatic men using this new blood test in the 1990s. Screening clinics every year where men of any age could come in, get a cup of coffee, a free PSA blood test, and a digital rectal exam. We would do more than 150 screenings in one day, and this went on across the country year after year. The intentions were good, to screen for cancer and disseminate knowledge about men's health and prostate disease, something that was lacking in the general population. One gentleman who came to our screening clinic thought that after getting his blood drawn for PSA, that the digital exam was going to be some type of a computer test. That is, until I showed him which digit I was going to use for the rectal exam. He wasn't happy about that. But it points out that we have had our work cut out for us in raising men's awareness about prostate health. It's now clear that indiscriminate mass screening with the PSA test is not appropriate and can cause harm. Overdiagnosis and overtreatment have consequences. Why did we do all of this screening, regardless of the age and health status of the men? Not only to raise public awareness, but prostate cancer can be serious and sometimes fatal, especially among high-risk groups, African American men, as well as those with a strong family history, germline mutations such as BRCA2. And by the way, disparities in prostate cancer outcomes among racial minorities is an important topic and a great area of research for those of you that may be interested in the fields of urologic oncology, epidemiology, and public health. Early on, the traditional paradigm that diagnosis would invariably lead to therapy meant that we were treating nearly everyone with PSA-detected tumors. Using surgery, which at the time was open radical prostatectomy or radiation therapy, we were producing devastating after effects in some patients that affected their quality of life, such as urinary incontinence and loss of sexual function. A patient that I was counseling years ago on treatment options for his newly diagnosed prostate cancer, there with his partner, said to me very bluntly that he would rather die of the disease than have an operation that would permanently damage his ability to have sexual activity. When I reflected on this later on, I realized that my discussion was so much on oncologic outcomes that I glossed over long-term complications and impact on quality of life, things that are important in the decision-making process. So despite this promising blood test and how excited I was by that very first PSA-driven biopsy, there was so much screening going on that it obscured any benefits of PSA-based early detection of prostate cancer. In the PLCO trial, for example, the control group was contaminated by the fact that at least 50%, and possibly as many as 90%, of the men in that study arm had at least one PSA test, making it nearly impossible to detect any statistical benefit of selective screening and early treatment. Then, in 2012, the U.S. Preventive Services Task Force stepped in and recommended against PSA-based screening, giving it a grade of D. Well, this certainly reduced PSA testing and biopsies, and it decreased the overdetection of low-risk prostate cancer. However, there was concern that it would lead to increased rates of advanced and metastatic disease. And data published just this year, 2022, in JAMA, suggests that the incidence of metastatic prostate cancer did go up significantly following the task force recommendations of 2012. So the answer is not to throw out PSA, but to use it more wisely by choosing men in more appropriate age groups and discussing with our patients the risks and benefits of screening. The task force later revised its recommendations along these lines. So educating patients and more selective screening are important in combating overdiagnosis and overtreatment. One of the other important tools is active surveillance, which makes sense when you consider that treating a cancer that is never going to cause morbidity or mortality can only cause harm. Today, a low-grade, low-volume lesion can be managed expectantly, and most men on active surveillance will not require intervention. The patients are monitored, and treatment with curative intent can still be offered to those who are later reclassified to higher risk disease. Long-term outcomes in active surveillance studies have been favorable, and as many as half of the men diagnosed with prostate cancer this year could qualify for that option. Research is ongoing as to the appropriate frequency of repeat biopsies, the role of genomic markers, and how imaging modalities such as MRI fit into the strategy of active surveillance. So the two messages that I want to leave you with today. Number one, shared decision-making and more selective screening with PSA reduces overdiagnosis. And number two, active surveillance is an important solution to significantly reduce overtreatment of prostate cancer. These measures are crucial when we consider the impact that local treatment for prostate cancer can have on long-term quality of life for men who are living with this disease. I thank you for your time.